Hello, everybody. So, as the Secretary of the outgoing Scientific Society, I'd like to thank you for having come in such large numbers, for being with us in the late afternoon, which means that I do not regret inviting Jean-Louis Masson and Samuel Jabert to close this afternoon's discussions. I'm going to try to convince you in 15 minutes that the sedation of ventilated patients is routine practice. In other words, it is frequent, it is important, it is something that we should not be scared of. In semantic terms, are we talking about sedation or analgesia? We should refer to both. And by way of a preamble to the discussion, all experts and all recommendations agree that analgesia in this respect should be the priority, that pain has to be assessed, that less pain means less sedation, less side effects, less toxicity perhaps, and finally that we must prevent delirium, which is a complication arising from the stay in the IC, probably associated with more morbidity and in some cases mortality. At least we have a first conventional wisdom, which is that sedating patients will favor delirium, and the latest recommendations from North America, as you can see, show or agree that there are divergent views on the relation between morphinic administration and low zolpidem on delirium, even though some sedatives may lead to less. So to talk about the present situation, yes, sedation is a routine practice. This recent German study, coordinated by Claudius Spitz, shows that out of 868 patients, of which 482 are ventilated, on the 369 who are monitored on a score basis, 3/4 are sedated in a moderate or deep way, with a RASS of less or 2. In the cohort of patients from Oceania, we see that this population, which is ventilated patients, ventilated over 24 hours, on average 5 days, 72% of patients have vasopressors, 25% are tracheotomized. These are patients from IC, and out of these patients, 2/3 are on deep sedation for 48 hours with RASS scores of under 3 to -3 to -5. And here you see the hypnotics and morphinics, which are administered even patients who are in IC for less than 4 days. Well, half of them have midazolam and 3/4 are given propofol. What are the goals of sedation with the ventilated patient? These are straightforward concepts. First of all, the first reason is to reduce respiratory distress, to encourage his adaptation to MV, to mechanical ventilation. And in this regard, Jean-Daniel Chiche has produced the preliminary results of a major study on 10,000 patients around the world that shows that at 1.20% of ventilated patients have ARDS syndromes. So these patients probably need sedation. Moreover, sedation reduces the consumption of oxygen and the production of CO2 for patients in a shock state. And again, it's 1/3 to 1/2 of intensive care patients who on admission are in a state of shock. With patients suffering from brain injuries, then we have to protect them from edemas and ischemia. But what we must also do is reduce the level of anxiety. Regarding patients who are in a severe respiratory state, cura has to be administered initially to the most severe cases, and by definition these patients have to be under heavy sedation. The mechanisms that are applied on the basis of their protective impact are better adaptation to protective ventilation, therefore a decrease in the lesions arising from mechanical ventilation, hence the importance for those patients of ensuring full respiratory adaptation. Now, I took the liberty of using this slide from Samir Jabert in order to emphasize the incidence of patients on controlled ventilation with diaphragmatic inactivity, a weakening of the diaphragm, but emphasizing nonetheless that the diaphragmatic strength decrease is a phenomenon that can be reversed. And in the study that we undertook on the benefit of the use of Cura, we see that a short-term use of Cura, 48 hours say, does not account for a higher incidence of problems related to intensive care. Furthermore, protective ventilation has become a priority in care for patients on MV, and we will see that not only this is used for patients on ARDS or indeed other categories. Regarding the most severe cases of ARDS, here's an example of a patient in our own ward, our own service, who is on the mend after a few days of controlled ventilation. Administration of Cura shows better gaseous exchange. Lower sedation follows, and 12 to 24 hours later, we see a renewed deterioration of his respiratory condition. This renewed deterioration is probably multifactorial, of course, but we cannot rule out that in this type of situation, the excessively quick decline in sedation from controlled ventilation to pressure ventilation, as shown on the right, may well account for this deterioration, because once the patient is allowed to make inspiratory efforts, major inspiration efforts, then what you may see is that through the combination on the right of the pressure rising from and the effort of inspiration, inhaling by the patient, shows a major increase in tidal volume that may bring about injuries due to ventilation. And this was shown on animal models, where you see on the red curve patients who have pulmonary lesions from whom we leave active spontaneous ventilation further to the lesion, and who will display much higher transpulmonary pressures than if we administered Cura sedative to these animals, and ultimately pulmonary histology that is far more severe. So the goal in saying all this, the point here is that a sudden stop or a sudden decline in sedation with these patients may lead to renewed deterioration. Of course, the literature argues for a link between heavy sedation and the extension of mechanical ventilation. This has been well established over the past 15 to 20 years. We all know that you sedate the critical cases, and they will be therefore ventilated for much longer. And closer to home, the same cohort I was talking about earlier, 250 patients ventilated for over 24 hours, for whom we see a link between the depth of sedation and the duration and survival in intensive care. Again, the direct link between sedation and survival is quite difficult to establish. A few intervention studies were implemented. They seek to encourage us to sedate patients less. The first of them goes back about 15 years. It was done by Congrès, monocentric study that included 128 patients. It was randomized for administration of sedation using midazolam or propofol morphine, and in the other group there was daily interruption. There was no protocol. no sedation score, and the daily interruption under monitoring by the medical team was either governed by complete interruption or renewed administration. So it's fairly severe cases of sepsis and ARDS. And what the authors noticed is that there was a decrease in the duration of mechanical ventilation. And we should point out that the ventilation was relatively short, as well as the stay in IC. And this is the first study that sought to make us aware that we were perhaps excessively sedating the patients. Perhaps there were no negative impacts on these daily interruptions, fewer signs of PTSD, but we should specify that these patients were assessed on the basis of a small sample. Some went further, saying that we should no longer sedate patients in intensive care. And again, a study closer to us, a monocentric study on 113 patients who were ventilated for over 24 hours, and the exclusion criteria fairly vague. Any patient who needed sedation was not included. Patients were randomized on a basis of a group without medication, morphine and bolus only, versus a control group that was the intervention group of the study done by Congrès. In other words, a constant sedation with daily interruption. Again, the authors show a significant decline in the duration of ventilation as well as the length of the stay. These studies are not meant to show any difference in mortality. And if we look at the methodology of the study, we see that the patients in the non-sedated group were given morphine, that there was one person who was specifically appointed to watch over them, that the ratio between nurses and patients is 1-to-1, and that patients were given Aldol if necessary, and if that wasn't enough, they were sedated using propofol for 6 hours. So you can just imagine what it happens if there's no sedation. And in the control group, this is a bit technical, the patients were maybe woken up a bit later when the FiO2 was 40% and the PP of 5. This may have contributed to a longer ventilation in the control group. The authors conclude that in most cases sedation was necessary in order to enable adequate oxygenation of patients suffering from ARDS. So looking at all of the above, what seems most reasonable, you don't need to read all this in detail, is what has been proposed for the past 15 years. In other words, that you should have in your service an appropriate protocol for sedation, ideally managed by the nurses. The efficacy has been demonstrated, enabling a duration in the decrease in the duration of ventilation. And when we reproduce previous studies in IC services where we have a sedation protocol, look at this more recent study, which is multi-centric, which includes 430 patients. The sedation was managed by the nurses with an evaluation based on the sedation score. And if in addition to that you add a daily interruption of the sedation, then there is no difference in the ventilation duration nor of the stay in the IC unit. And to conclude, the recommendations at present are to maintain, if possible, a low level of sedation, while recognizes that the combination of the depth of sedation and the psychological stress arising from it is not, this link is not quite clear. We need to titrate the sedation. And in conclusion, I hope I've convinced you that sedation is a routine practice that is very useful. It's more important to properly sedate rather than not to sedate. Yesterday, I was hearing Thomas Silisevsky, who is a specialist in MV, telling us that in his view, best clinical practices, in other words, having a patient who is completely awake, who breathes by himself, dyspneogenic principles. It's difficult to resist paramedical pressure. Sometimes from nurse, a sedated patient means he's under heavy sedation, but probably the best way of convincing them of the opposite is that you should provide them with the contract and let them manage sedation properly on the basis of the protocol. And the questions you have to ask every day in your IC unit is, do we need the same doses of analgesic and sedatives? Should we not dissociate the two? And finally, a common sense question is there a risk of accumulation with my patient? Because the risk behind all this, or the fear we have, is that we're going to be late in waking the patient up and bringing them back to consciousness. And of course,